Well, welcome back, and we're going to be starting our afternoon presentations. I'd like to welcome Dr. Larry Pickering, who is with the CDC National Center for Immunization and Respiratory Diseases, and he's going to be presenting on the Advisory Committee for Immunization Practices. And I just have to say, I mean, last night was very exciting because we had a major tour of Philadelphia International Airport, and both folks were very, very good about it. But the other thing is that I've been trying to get Dr. Pickering here for 2 years, and he's been just very wonderful about all the correspondence and the back and forth. But let's welcome him. I think you will really enjoy his presentation.
Thank you. Thank you. Can you move it forward? It's just right here?
Yeah, you just do here or here.
Okay.
And a page up and page.
Thank you. Thank you very much. It's a real pleasure to be here, and particularly to talk about the Advisory Committee on Immunization Practices. I have no financial conflicts of interest to declare, as stated on this slide. And there are 5 things that I'd like to do during the course of this discussion. Really 6. One is to finish early, but I won't accomplish that. So I'll do these 5 that are on the slide. One is to discuss the responsibilities, the structure, and the function of the ACIP. And it's a very complicated committee. Hopefully I'll try to simplify it during the course of this discussion. Secondly is to review the process of immunization policy development in the United States. Thirdly is to summarize the interactions with professional organizations and society. That's one of the real successful things that we have in the United States that other countries don't. There are 8 vaccines that were available in 1986, and now we have 17. And for some reason, I'm not all showing, but we'll move forward. And that's good. The complexity of the immunization schedule is due to the number of the vaccines we have and also the specific recommendations for each of those vaccines. This is a little bit about the background of the origins and role of ACIP. It was established in 1964 by the Surgeon General of the U.S. Public Health Service in the United States. It was designated as a Federal Advisory Committee by the Federal Advisory Committee Act in 1972. And what that means is that we just have a group of rules and regulations that we need to follow. The role of the ACIP is to provide the advice and guidance to the CDC director about the utilization of vaccines for the civilian population in the United States. The military has their own recommending body, but basically where there are similar vaccines, we try to utilize the same recommendations for both groups. The military has a lot of vaccines that they give our troops that we don't use in the civilian population. And what we deal with, or what ACIP deals with, are vaccines and related agents, such as antisera, immune globulin, and antiviral agents, particularly the antiviral agents for flu. But the major thing are the FDA licensed vaccines. That's the major bulk of the work that ACIP considers, is making recommendations for licensing. And remember, FDA licenses vaccines, and then the ACIP makes the recommendations for the use of those vaccines, generally following the licensure restrictions placed on them by ACIP, by the FDA. Now, the second major thing that ACIP does is they deal with the Vaccines for Children's program. VFC was established in 1993 and operational in 1994 under President Clinton, and it's a very unique statutory authority that gives ACIP the authority to determine vaccines provided for the VFC program. ACIP members will vote on a vaccine, and then that vaccine immediately afterwards is voted into the VFC program if the vaccine covers people 18 years of age and less. So it's an entitlement program that once it's voted in, all children 18 years of age and less are entitled to get that vaccine. Now, who's eligible for the VFC program? Well, unfortunately, about 48% of children fall into this category. Many of them, of course, are underinsured or in very poor families. The other eligible children then are for Medicaid, uninsured, American Indian and Alaskan Native populations, and the underinsured. The VFC program is a federal entitlement program that currently runs about $3 billion, so it's a large one. The big advantage, of course, is if we didn't have the VFC program, many children in this country would have no means to get their immunizations. Now, another major responsibility that ACIP will have, depending on what happens, we know that the Supreme Court ruled on the Affordable Care Act, and the justices ruled, or at least 5 of them did, that the individual mandate was constitutional. In the wording of the Affordable Care Act, it states, vaccination coverage was explicitly addressed in the statute, requiring that all health insurers provide all recommended vaccines with no copay and no deductible to people in the United States. So if the Affordable Care Act holds up, everybody in the United States will get their immunizations free of charge. Now, what about the development of a vaccine? This slide goes over it, starting at the top. A vaccine will be developed by a manufacturer. It'll be tested after many, many years. And most of the vaccines never make it to market. But if they make it through this process, then we, of course, will all benefit from them. Once a vaccine is felt to be ready for submission, it will be submitted to the FDA for what's called a biological license application. So the BLA is filed with the FDA. The FDA then will take a period of time to review all the boxes and boxes of material that are submitted. And when they feel that the vaccine is ready for consideration, they will ask their Vaccines and Related Biological Advisory Committee. This is their advisory committee to give them a recommendation about whether this vaccine should indeed be licensed. The VRPAC, as it's called, meets in an open meeting, makes recommendations either for or against a vaccine, and then the FDA considers those recommendations, may go back to the manufacturer for more information, and if things work out, it will be licensed. At that time, the licensed vaccine is considered by the Advisory Committee on Immunization Practices, and also by another committee, the Committee on Infectious Diseases, the American Academy of Pediatrics. They consider all the facts, all the information, and then they come out with recommendations. The recommendations for the CDC are then published in MMWR and the American Academy of Pediatrics in their journal, Pediatrics. Then it's up to the states and others to institute the uptake and the financing of this vaccine. ACIP does not really deal with specific uptake or with specific financing of vaccines. That's left to parties after it passes through the ACIP. Now, what about the structure of the ACIP? It's very interesting because there are 15 voting members. They're all non-government employees, many of them from academic, state health departments, and other places. The other thing, there are 30 liaison organizations. These are non-voting members. Each of the liaison organizations attends each ACIP meeting, and these are the professional societies that ACIP works with. There are also 8 ex officio members. These are government agencies like Medicare, Medicaid, NIH, FDA. These are people in the government that represent organizations that deal with vaccines. So for instance, if the ACIP member has a question about Medicare coverage of a vaccine, we have a representative there. If we've got a question about FDA and why they did something or want further information, the person's there and can answer it right away. The ACIP reports to the director, and the ACIP recommendations are not official until approved by the CDC director and published in MMWR. About 2 years ago, 18 months ago, we started webcasting all ACIP meetings. So if you can't make it to Atlanta to the open public ACIP meeting, you can spend very exciting 2 days watching the ACIP meeting on the webcast. And I'm sure that block off the whole 2 days, because once you tune in, you won't want to tune out. No, that's, why are you laughing? That hurts our feelings. That hurts our feelings. The ACIP makes vaccine recommendations for all ages, whereas the American Academy of Pediatrics, their recommendations go from 0 through 18 years of age. Now, the structure of the committee, there are 15 voting members, including the chairperson. As I said, they're all non-government employees. They serve 4-year terms. The ACIP Steering Committee, this is a group of 15 people, of very senior ACIP employees, FDA, the chair and vice chair of the committee, will make selections, submit the names to the Secretary of HHS. The Secretary then usually approves the names, and then those individuals are appointed to the ACIP. There's one consumer representative on the ACIP, and the members undergo a very rigorous screening for conflicts of interest, because this is something that's critically important. We cannot have members on the ACIP that have financial conflicts. So to get on the committee, they undergo a set of screening procedures, and once on, they undergo another set. Now, the other people that are around the meeting, and there are about 400 or 500 people at an ACIP meeting. There's the inner table, which is the ACIP members, and the outer table, which are the 8 ex officio members that I mentioned, the 30 liaison organizations that I also mentioned. And then behind the scenes, there's ACIP work groups. And the work groups are sort of the engines of ACIP. They gather and collect all of the data then that are eventually presented to ACIP in the formation of raw data that is discussed and, of course, recommendations that the ACIP then will accept or not accept. Now, once a recommendation is made, it's really important to get that recommendation out into the public, because it isn't really the official CDC recommendation until it's published in MMWR. So we've shortened the process for doing that. On the left-hand side, and what we do with most of our recommendations now, we put them out as policy notes. These usually are published within 1 to 2 months after an ACIP meeting. They've gone through all the clearance from the CDC, all the ACIP members have signed off on them, and the director has approved them. Then they're published in MMWR. Sometimes we have a longer process, and these are called the recommendations and reports. These will sometimes take up to 9 to 12 months to be published. And what we're doing now is that the R&R is generally more or less a summary of 4 or 5 different policy notes, putting them all together in one document. The meningococcal recommendations now are in clearance, and they've gone through clearance and will be published probably within a month or two in MMWR. And they will summarize all of the somewhat complicated recommendations for the use of meningococcal vaccine. Now, this is the most recent, excuse me, this is the most recent publication by ACIP. It's an updated recommendation for use of Tdap in people 65 years of age and older. Remember that Tdap was originally not given to adults because it wasn't licensed. When it did get licensed, it was given. And this is one of the instances where the FDA licensure of a vaccine is different than the ACIP recommendations, and there are a few of those. The reason that occurs is that for an insert to be changed, the drug company has to propose that and prepare the information for the FDA. And they're loath to do that because of the huge amount of work that it takes. The CDC and the ACIP, I mean, the ACIP, on the other hand, looks at new data as those data are gathered and then makes recommendations for usage based on those new data. So that's a little bit difference in the process and in some of the vaccines with regard to their licensure and to regard to the recommendations. Now, what about the expertise of ACIP members? Why are these people chosen, and what qualifications do they have? Well, there are 15 ACIP members, and there are 12 qualifications listed here. Many members have more than one of these qualifications. Now, there are 5 of the 30 organizations. Uh-oh. Is it just in case? Okay. That's scary. Thank you. Many of the 30 organizations, 5 of them participate actively in developing the immunization schedule. The immunization schedules, both the childhood and the adult that come out, aren't just an ACIP schedule and aren't just a CDC schedule. They're part of a group of unification of various organizations that put out the schedule, and I'll talk about that in a moment. Now, these are the bodies that support the vaccine schedules. The childhood schedule is a joint publication between ACIP, or CDC, the American Academy of Pediatrics, and the American Academy of Family Physicians. The adult schedule, on the other hand, is a combination between the CDC and ACIP, the American Academy of Family Physicians, American College of Physicians, and OBGYN, our colleagues there. So it's the same schedule that everybody puts out. We don't have differences in making recommendations. So the CDC promotes the schedule, and all the professional societies, these 5 of which have helped develop the schedule. It's a unified promotion of unified recommendations. We are also working now to have our nursing colleagues become part of this process, and that's in the works right now. Now, what about the ACIP work groups? What do? They work hard. Our work groups are very hard working. They gather, analyze, and prepare information for presentation to the ACIP. Now, when has this begun? As soon as we hear that a vaccine has been or will be submitted to the FDA for a BLA, or as soon as the FDA licenses a vaccine, our work groups are formed. We usually form them before the BLA is submitted, if we know that's going to happen, so that data can be gathered and begin to be presented to the ACIP. We have probably 2 or 3 presentations of data before the vaccine is licensed by the FDA, and maybe 1 or 2 presentations after that, because we want to make sure that all of the ACIP members are fully aware of all aspects of the vaccine upon which they'll be voting. The ACIP work groups develop draft policies and options for review by the full ACIP. And they meet at least every month, and before an ACIP meeting, they'll meet by teleconference every week to finalize all the data that need to be presented. Now, the work groups are chaired by an ACIP member, as I said, and at least 1 other ACIP member is on each work group. So you've got 2. Most of them have 3 or 4. Other members, as I mentioned before, lead staff, other CDC staff, including Immunization Safety Office. Every work group has an immunization safety person on there that oversees and makes sure that all aspects of safety of the vaccines are considered. We have liaison representatives and invited consultants as needed. They are task-oriented. There's 2 types of work groups that I'll show here. There are the permanent work groups. There are 4. And then there are the task-oriented work groups. I think we have 7 or 8 of those now. The permanent work groups are permanent because they put out something regularly. For instance, the adult immunization schedule is published every February, and we just changed that last year from January to February. So both the adult and the childhood schedules will be coming out in February from now on. The general recommendations come out every 3 to 4 years, so this is a permanent group. The harmonized childhood schedule comes out every year, and of course, influenza recommendations change every year. And they should be out probably in August. And they'll be published as a policy note. They'll be very brief, easy to read and easy to understand. And then there are various task-oriented work groups. So if you ever want to know what to expect with regard to a vaccine, just look at the work groups, because there's something going on with the vaccine in that work group, meningococcal pertussis and so on. These are work groups that sometimes have been formed for 1 or 2 years because there's a lot of changes that are occurring in various recommendations. Now, I mentioned that the ACIP puts out not only regular immunization updates, but they also put out the general recommendations on immunization. Everything you want to know about a generality of an immunization that's applicable to all the immunizations are published here. So it used to be we had probably about 7 or 8 of these different things on how to store vaccines and how to do this and how to do that. We've now standardized it all into this. This is very similar to Section 1 of the Red Book. We've got a lot of the information in there. And lately we've really tried to coordinate the Red Book. For those of you who aren't pediatricians, that's the book that the pediatricians follow, and the general recommendations so that the recommendations are similar. Then, immunization of healthcare personnel was just published. This was published in November of last year, and it updated the 5 or 6-year-old document on what all of us who are healthcare personnel should receive as far as immunization. So anyone that's interested in this can get it, and you can read it before you go to sleep. But again, it's a real page turner, so go to bed a little bit early. Now, what about the process of ACIP? There are 3 meetings that are held annually, and they're open to the public, and they're public comments. So you can make comments about what ACIP is doing or saying, or try to make comments for them to consider before votes. The agency items, topics, as I said, are solicited from various groups. The agenda is finalized by the ACIP Steering Committee. The agenda is always put on the ACIP website a month or 6 weeks before the meeting as draft agenda, so everyone can sort of get an idea of what will be presented. We follow all the rules and regulations, including having all meetings open to the public. Now, the interesting thing is that after the meeting, we post all the meeting slides on the ACIP agenda. The live webcast is archived on the ACIP website, and the minutes are posted about 90 days after. And the minutes are about 100 single-space pages, so there's a lot of stuff in there, but they're a lot of information. So anyone who is interested in looking up something after an ACIP meeting, it's all available. And as I said, the recommendations don't become official until approved by our director, Dr. Frieden, and published in MWR. Now, one of the things that we've done is try to standardize how the ACIP operates, so we don't have to reinvent the wheel with every recommendation that comes out. And there are 5 standardizations that we've implemented over the last couple of years. One is we've standardized the way the wording is presented for immunizations in pregnancy and women who are breastfeeding. There's nothing in here that says what types of recommendations are supposed to be given, but the wording in the MMWR policy notes that come out recommending Tdap in pregnant women or recommending influenza in pregnant women, the wording is similar, so that vaccine to vaccine is given in a similar manner. Economic analysis guidance has been established. We used to hear economic analysis of vaccines, and they were so confusing. I remember in college taking economics, and it was kind of boring. And now we made it exciting because we have a standardization of how our economic analysis are presented. Some members may not understand what's being presented, but at least they know that it's presented in a standardized format of very high quality. All of the economic analysis are reviewed by CDC or academic economists before the meeting to make sure there are no glaring errors. We all know epidemiology studies, or many of us, are clinical studies, and that's why we standardize the economics. Acronyms and abbreviations have been standardized between the CDC, the AAP, the AEFP, and other organizations. Provisional recommendations will be put out if we indeed see that a recommendation will not be published for a year. We'll put provisional recommendations out on the website. And of course, the evidence-based recommendations have been instituted, and if I have time, I'll talk about those. Now, now I have time. In October of 2010, the ACIP voted unanimously to adopt a methodology to assist in development of clear and uniform evidence assessment and reporting for future ACIP recommendations. The system used is called Grading of Recommendations, Assessment, Development, and Evaluation. It's called the GRADE framework, with which many of you are familiar. The GRADE was implemented a year later after a lot of education was given to the people who will be doing the grading of the evidence. In October of 2011, the first 2 recommendations were graded: hepatitis B vaccine in males and hepatitis B vaccine in people with diabetes mellitus. And what GRADE does simply is it takes recommendations, or takes data, and it analyzes the data and then tells about the quality of that data. Then when the recommendations are made, there is some sort of a quality of data evaluation that help formulate the recommendations. Now, it's interesting, shortly after this, or around about the time, the Institute of Medicine came out with 8 standards for developing rigorous, trustworthy clinical practice guidelines. And we were moving forward at ACIP, SAGE was moving forward, some other developing committees were moving forward. So once I got these, I said, I don't know if I want to read this because we may not be doing everything that the IOM says we should. But when looking at it, it's interesting. Establishing transparency, that's exactly what GRADE does. It tells you that a recommendation was made based on this quality of data. Management of conflict of interest. ACIP is extremely rigorous about our conflicts of interest. Guideline development and group composition, again, that's very transparent for ACIP. Evidence based on systemic reviews, which is now the GRADE system. Method for rating strength of recommendations is part of the GRADE system. articulation of recommendations in a standardized format, and we do that in the types of publications that we have, and real clarity in wording about what the recommendation means. External review, I can tell you that we have 30 professional liaison organizations, our 8 ex officios, and all of these work group members. These things get reviewed to the hilt. So the external review is covered very well. And then, of course, updating. What we do with ACIP is that all the recommendations are reviewed every 3 to 4 years, and they're either retired, renewed, or reaffirmed. Very similar to what the Academy of Pediatrics and ACP and others do. So recommendations are not left to languish. They're updated on that basis. Now, the ACIP process, you can say, well, you talked about the grade, but what evidence is considered in the immunization policy development? What does this grade process do? What does it consider? Well, first of all, the major thing that ACIP does with vaccines is they wait till the FDA licenses it and follow as much as possible the indications in the schedule. So almost always when a vaccine is newly licensed, the ACIP will follow almost exactly what the FDA has licensed that vaccine for. Disease burden overall in high-risk groups. We will recommend pertussis vaccine for everybody because it's a major disease in all the population. We don't recommend rabies vaccine for everybody because we only see 1 or 2 cases in the United States a year. In some countries where rabies is endemic, that may be different. Vaccine efficacy and effectiveness, does it work? And what percentage of people are protected once immunized? These are data that are considered. Safety is a major concern of the ACIP, and that is monitored throughout the whole process before, when the recommendations are made, and then there is a report at every ACIP meeting on the updated safety of a vaccine that the FDA licenses. So every meeting we will hear safety updates on vaccines that are licensed, so that if there are safety concerns, they're dealt with immediately. Feasibility in the context of the existing recommendations. The immunization schedules, as you know, are fairly complex. This is a consideration, how it fits in with everything else. Equity and access to vaccines and good use of public funds. The CDC really doesn't consider cost in the deliberations. It's not one of the things that's graded. However, everybody looks at cost effectiveness and considers it in some way in the recommendations that they made. And it's not official, but you can't help but think there are some unofficial areas. And then recommendations of other group, as I said, the other groups, we harmonize the recommendations among and with our professional society colleagues. Now the recommendations now are grouped into 2. Category A, these are recommendations that are made for all people in an age or risk factor-based group. So everybody gets this vaccine in the population. If you recommend meningococcal vaccine, Dr. Fisher was just talking about the meningococcal vaccine recommendations for adolescents, 11 to 12, and then 16 you get a booster and older. So those are pretty much recommendations for everybody. And then there are also recommendations for that vaccine for high-risk people in other age groups. Category B are recommendations that are made for individual clinical decision-making. Not a decision-making by an insurance company, but a decision-making between a patient and a physician or a nurse practitioner. And then evidence tables are used to summarize benefits and harms and strengths. So there's these really cool tables that have all the evidence in there, and they rank them as the strength of the evidence, and you can up-regulate or down-regulate some of the recommendations based on other data. These are all posted on the ACIP website. So if anyone wants to look and say, why did they make that recommendation? You can go to these evidence tables and find out. Okay, I'll skip that. Now, the CDC resources for learning more about grade are listed. I've listed a couple of them here. These are all on the ACIP website. So you can get a full description and answers to frequently asked questions about grade, or you can watch an 88-minute video on grade, or if you're really into it, you can watch part 2, which is a 100-minute video on grade. And then even more, you can look at some slides. So the educational material is really there for people to learn from. And if you don't want to do that, there's a very good article that was written by Farouk Ahmad that was published in Vaccine. There was also another article that has just come out in vaccine on the SAGE process for grade. So both of our committees have put their information out. It's interesting when you look at the authors on this. Holger Schrenemann is sort of the grandfather of the grade system. He's a Canadian, so it's pretty logical. And Farouk is a person at CDC that is helping us through this process. And then John Temte and Douglas Campos-Allcalt are two ACIP members. And we've been very fortunate to have their expertise as we go through this grade process. It's utilized by several organizations that are listed here. Over 60 to 70 organizations use this. And the good thing about it is that it's a uniform approach so that the organizations all are utilizing the same process. So you don't have to learn a bunch of different processes. You only have to learn or understand one. Now, what are the immunization products? How are we doing on time? Couple minutes. The immunization policy products, 2 immunization schedules are out there. I won't talk fast, I'll go slower. There are 2 immunization schedules that are out there. And the important things to remember about those are that they're harmonized, number one, and then both schedules, the adult and the childhood schedule, are updated regularly. The pediatric schedule is going to be updated this year. They're changing it. The format of the pediatric schedule, you can see here, there are 2 different schedules, 0 to 6 and 7 to through 18. They're going to put them all back into one table. So that's going to be one change. Number 2 is all the footnotes. There won't be 2 sets of footnotes. There'll be 1 set of footnotes for the whole table. That's going to be a big improvement. And then the third thing that I really like, I'll talk about it in a moment, but there are 2 of the major changes, and I'm going to tell you the third one in a minute, and this is supposed to keep your interest. So I'll tell you about that in a minute. But there will be now these changes to the immunization schedule, the childhood schedule next year. Now the adult schedule is really, it's a neat schedule because there are 2 schedules here. The one on the left shows immunizations that adults should receive by age group, 19 to 21, 22 to 26, and so on. And then it lists the types of vaccines that are there. The one on the right at the top across lists all conditions, pregnancy, HIV, splenectomy, and so on. So it tells you all the various conditions. So if you have a patient that comes into your office with HIV, you can look and see what vaccines that person should get. So the third thing I was going to tell you about the childhood schedule is that similar type of table is going to be included in the childhood schedule. So that when we see a child that comes in with leukemia and we're not sure about what vaccines he or she should get, it should be on the table. So it's going to be, I think, 3 big additions that are very positive to the childhood schedule. The adult schedule will have minor changes to it. And of course, anything you want to know about a vaccine is here. And this is the real meat of the vaccine tables, or the fine print. The childhood schedule, you won't have to read 2 fine prints, so they'll all be combined into one. The adults will still have one. And it's interesting when you look at this, almost any question that I'm asked is answered in these footnotes. The committees that make these, the work groups that make these footnotes and are approved by ACIP really put a lot of time and effort into try to keep them simple but contain all the information that you need. Now these are a couple recent ACIP recommendations. Again, all of the recommendations are on the ACIP website. PCV 13 use among immunocompromised adults was in June. Influenza vaccine recommendations were in June. These are the approvals. Not all of these have been published yet. These are the approvals, and these will be published in the near future. Flu is going to be in August. PCV 13 may be a little delayed. HPV in males has been published, as have the child and adult schedules, and HPV in adults with diabetes has also been published. So, and this is the ACIP website. I think it's pretty easy to navigate. It's been redesigned by our webmaster. So this is the older version. The newer version is even easier to use. So anything you can find, you will be able to find on the ACIP website. Now lastly, these are some of the future considerations. These are some of the things that we're all going to have to deal with regard to immunizations. We've done the easy things. We've taken the ACIP and the advisory committees have made the recommendations. Now, as more data are gathered, all these things are fine-tuned. And this is where, to me, it gets fairly complicated. And I've listed those. Number 1, how long does Tdap protect? Probably 5 years. Okay? Tdap was recommended 5 years. So, Dr. Fisher, what are you going to do now with Tdap? I got my Tdap in 2006, and that's 7 years ago. So should I get another Tdap? The committee is looking at this, and it is a tough one. There's no single antigen pertussis vaccine. The only thing to re-give is another Tdap vaccine. So that's a real consideration. So we can ask Dr. Fisher afterwards what we should do. Use of PCV13. Yes. Use of PCV13. PCV13 is now being used in children. What are we going to do with this vaccine in adults? You know, the polysaccharide 23 vaccine has 23 of the antigens in there. The PCV13 has 13. And those 13 only cover about 50 or 60% of invasive pneumococcal disease in adults. So probably don't want to use that alone. Well, how are we going to use that? They're considering it. Use of meningococcal vaccines in infants, under consideration. What about zoster? We had a really good talk this morning about zoster vaccine. Zoster vaccine is licensed down to 50. ACIP hasn't recommended it yet for 50 to 60 because there was a shortage. So what are we going to do now? Are we going to recommend it for 50 or leave it the way it is? It's under consideration. Influenza is going to be very exciting. There's a quadrivalent vaccine that will be available not this year, but next year. There are new adjuvants that are being added. There are higher doses and different doses of the vaccine, so there's a lot going on with influenza. Mumps protection. There have been outbreaks of mumps, and people are looking at a third dose mumps vaccine during outbreaks. That's going to be discussed at the ACIP meeting. And vaccine hesitancy and pseudoscience, we've heard about that. That's a big issue. I don't have enough time to talk more about that. But that is something also that ACIP is considering. We don't have a work group like Dr. Abramson said SAGE does. But there's a lot of work going on both at the American Academy of Pediatrics and at CDC on vaccine hesitancy and the pseudoscience associated with it. So, I'm finished. So thank you, and I don't know if we'll have time for questions, but...
Yeah. Thank you, Dr. Pickering. That was a great presentation. Thank you for sharing everything we ever wanted to know about ACIP and the process, and thank you for sharing your passion with us. That was great. Personally, professionally, I'd like to say thank you for all the standardization that's gone on. It's really, for those of us who do go to bed with those recommendations, having the last few years, the most recent changes have been really important, and we look forward to the changes with the children's schedule, childhood schedule. Thank you.
Simplification is what we need. I mean, it's hard enough as it is without making it more complicated with recommendations. So, yeah.
Right. Thank you. So, a question that we had was what's the typical time frame for the FDA approval of a new vaccine formulation usage to final ACIP published recommendations?
Yeah. Generally, they put some rules and regulations so that after a BLA is submitted by a pharmaceutical company, it's about 10 months, maybe 8 months, but 10 months, something like that, that they have to make a decision on that vaccine. Now, that 10 months can be a little bit delayed because if they request more data, or if they think that the pharmaceutical company hasn't submitted enough data, they may request it and that may be extended. But generally, it's about 10 months. A pharmaceutical company can apply for an expedited review, and of course that time is much shorter. So generally within 10 months you'll hear something, but oftentimes it may be a little bit delayed if new information is needed. And then once the BLA is accepted and discussed at the public open meeting by VRPAC, their advisory committee, then it goes back to them, and then it's usually a couple more months before you'll get a final FDA recommendation.
Thank you. Another question, is it permissible for VFC providers to follow ACIP recommendations if they differ from the manufacturer's statements in the package insert?
Yes, it is, because generally as I said, once an ACIP recommendation is made for a vaccine, it's voted on immediately by VFC, and therefore it's in the VFC program. So any vaccine that is a VFC vaccine can be given because it has been approved for that use by the ACIP. So it is definitely permissible.
And one final question. If you could just tell us, I was curious, what's the criteria for that one consumer member who serves on the ACIP? Is it usually somebody who has attended the open meetings on a regular basis, or, is there some formal criteria to be the member? Does the committee pick them, or is it somebody who says, I'd like to be the consumer representative?
Well, that's a hard question, because what is a consumer representative? There isn't any. I mean, there isn't a perfect person that can fulfill all the criteria. We have written criteria that we utilize, but just a few general things are, number one is the person needs to have a general knowledge of vaccines. Secondly, the person has to be intelligent. Thirdly is that the person has to feel comfortable speaking up in an environment that is sometimes inhibitory. I mean, this is 400 people's webcast, the media is there, everything that happens at ACIP is in the paper the next day, so you have to feel comfortable. Fourthly is somebody that can get along with the rest of the committee members. And then we have a selection process that nominees will be submitted, and then we have a selection process to try to pick the best person. This is a very difficult situation, because you don't want the extremes on either side. You want someone that is sort of in the midline, that is willing to be critical of vaccines, but also recognizes their importance. We don't want to pad it with just getting anybody that's going to rubber stamp everything. And in fact, our consumer representatives have not done that. We've been very fortunate in the past, and hopefully we'll continue to do it in the future. The way that it's done is all the CVs are sent in with a letter of recommendation. They're all considered by the steering committee. The steering committee then will submit two names, a primary and secondary person, to the secretary, and then the secretary of HHS will generally approve or not approve those two names. We do what I consider a really thorough job of making sure all the conflicts are removed, and that the secretary will choose a first or second nominee, and that's happened in all cases so far, so we've been fortunate. And anybody who's interested in applying for consumer rep of the ACIP or as a professional member, go to the ACIP website. The instructions on how to do it and what's needed are there. We'd more than welcome names of people. So if anyone is in the audience wants to become an ACIP member or consider it, you can either call me and we can talk about it, or look at the ACIP website to get information. Okay, good.